It is well known that the healthcare system in USA is broken, be it rising costs, inadequate access, inconsistent coverage, or surprise bills. We have it all. Healthcare expenditure per capita in USA is the highest amongst developed nations, which unfortunately doesn't translate into better outcomes. One of the ways to tackle this system is the hospital at home model. My name is Rohan Bhojwani and we are Team 5, and we hope to share how this model could be one of the ways in mending our broken system. So what is this model? The way this model works generally is described as follows. So a patient is identified who is sick enough to be hospitalized but stable enough to be treated at home. Narrowly defined eligibility criteria help distinguish such patients, and conditions such as heart failure, pneumonia, and cellulitis are a natural fit. Then the suitability of the home is assessed to confirm availability of proper amenities. Then responsibility for care is assigned to a physician. A greeter meets the patient in the ER and helps with arrangement of the logistics of the entailing care. A caregiver then meets the patient at home. Orders are written and clinical staff arrive as needed to administer care and conduct tests. Meals are arranged if necessary, and the patient's vital signs are monitored electronically. The physician visits the patient daily and ensures continuous improvement. And once the patient is stabilized, he's handed off to his or her primary care physician. And in one model, the providers maintain oversight of the patient for at least 30 days. This will be the following agenda in our presentation. So how did it all begin? In 1995, Dr. John Burton of Johns Hopkins School of Medicine, in conjunction with Dr. Regent Strife, conceived the new program to provide safe and effective hospital-level care at home. In 1996, a 17-patient pilot trial showed that hospital at home was feasible, safe, and cost-effective. In 2000, National Demonstration and Evaluation Study tested hospital at home in 3 Medicare centers and 1 VA center. In 2002, hospital at home was objectively more widespread than ever. In 2010, a partnership between public and private sector tested a modified model for hospital at home in which telemedicine was also included. In 2011, Clinically Home was formed to develop and commercialize the telemedicine-based care model. And in 2015, a project to test a possible 30-day bundle payment model was introduced by Medicare. This was important because Medicare adoption of this model has been slow in United States, but the pandemic has changed that. In the age of COVID-19, hospital at home offers additional upsides. It can help conserve PPEs, frees up bed space during COVID-19 surges, keeps infected people out of hospitals, and addresses patients' fear of contracting the disease while receiving other care. Now, I would like to pass off the slides to Bilgisu.
Thank you, Rohan. The hospital at home market has seen significant growth since the COVID-19 pandemic started, with the global market size valued at 320 billion as of 2021, and it is estimated to reach 520 billion by 2027. While hospital at home care has been slower in the US, the market has also been shaped by robust growth, with the market size estimated at 113 billion in 2019. The market size is expected to grow at a rate of 7.3% over the next 6 years. The recent rapid growth of hospital at home program was mainly driven by the coronavirus pandemic, the cost efficiency, improved patient outcome, and the convenience offered by the program. It is also important to note that the North American region accounted for 42% of the global market revenue in 2020. However, this may change in the future as other regions adopt more the hospital at home model. The hospital at home program has a broad range of stakeholders. These stakeholders include consumer groups that are made of patient, family, and caregivers. They are primarily interested in treatment option, benefit and harm, as well as the quality of life brought by the program. We also have the healthcare provider group, which include healthcare institutions and clinicians. This group focused on clinical outcome, treatment options, the quality of care, as well as cost efficiency brought by the program. We have policymakers as well as the third stakeholders who are at the federal, state, and local level. They have a strong take on regulation and the program effectiveness on population health outcome. Payers are another important stakeholder in this program. They include employers, public and private insurance companies. They're also interested in the cost efficiency of this program. We finally have the collaborator and sponsor group, which is composed of patient advocacy organizations, community-based services, research institutions, and key service leaders providing ancillary services such as pharmacy, diagnosis, and social work. While the stakeholder interests vary, they do have some converging interests related to access, cost, efficiency, quality of care, as well as the patient well-being and quality of life. The emergence of the coronavirus in 2019 increased the demand for hospital-at-home programs significantly. As a result, over 150 hospitals across 29 states in the US implemented the hospital-at-home initiative during COVID. Findings on the hospital-at-home program performance shows significant cost savings of nearly 30% compared to inpatient hospitals. They also found a 24% decrease in readmission rate and 20% reduction in mortality rate for the hospital-at-home program. This includes shorter acute period, averaging 3 days, and improved patient satisfaction. The hospital-at-home potential to improve care and reduce health expenditure offer compelling incentive to market players to continue expanding the program. We have seen significant market forces showing interest in developing and expanding hospital-at-home program. For instance, industry leaders such as Kaiser Permanente and the Mayo Clinic recently formed a coalition to expand access to care at home. Healthcare organizations operating in the hospital-at-home ecosystem also estimated that 25 to 30% of inpatients could receive care from a hospital at home. While the new payment support from CMS offers a good prospect for the hospital at home program, there is still some work to be done to help the US healthcare system and insurance company overcome reimbursement challenges, remedy to the absence of standard for equity, quality, and safety for hospital at home program. Now I'll pass it over to Amanda, who is going to talk about the requirement for success.
Thanks, Bilgisu. The hospital at home program technology requirements are two-pronged. First, patients must be equipped with the appropriate tactical gear. This includes remote monitoring devices such as Holter monitors, biofeedback tools and wearables like activity trackers, and fundamentally a reliable Wi-Fi and phone connection. But of course, a tool is only as effective as its user. Technological literacy and/or support from the patient's caregivers and advocates is critical for appropriate implementation of these technologies. Additionally, hospital at home patients often receive the benefit of MIHP, Mobile Integrated Health Paramedics, defined broadly as the provision of healthcare using mobile resources in the out-of-hospital environment. These paramedics are often partners in the local EMS or emergency medical service department. Hospital at home programs require at least 2 in-person daily visits from an RN or MIHP, as well as daily evaluations with an MD, medical doctor, or APP, advanced practice practitioner, as well as staffing for auxiliary services, including meals, labs, imaging, and therapies. Finally, a physician or a nurse must be accessible to the patient 24/7 and be capable of an emergency response within 30 minutes. In November of 2020, CMS, the Center for Medicare and Medicaid Services, announced the creation of a short-term waiver for acute hospital care at home programs to address COVID-19 related capacity issues, allowing individual hospitals to receive inpatient payment for providing acute level services to Medicare beneficiaries in their homes. These payments are based on the average resources used to treat Medicare patients in a particular diagnosis-related group, or DRG. Services must include, but are not limited to, pharmacy, respiratory care, diagnostics, DME, durable medical equipment, social work, to name a few. Hospitals can apply for the waivers in one of 2 tiers based on their experience with the hospital at home program. It's also important to note that patients can only be admitted to the program from emergency departments or inpatient hospital beds. Again, admission to a hospital at home program is considered an intra-facility transfer from the ED or inpatient hospital to the patient's home. Patient candidacy for hospital-at-home programs is determined by a physician, and over 60 acute or acute on chronic conditions can qualify, some of which are listed here. Patients are disqualified if they require ICU, intensive care unit level care, if certain socio-environmental risks are present, such as incarceration, absence of sufficient heating and air conditioning, or domestic violence, if the patient faces potential clinical access issues, such as delirium, a need for pain meds that are considered controlled substances, or ambulatory deficits impacting toileting. And finally, there are pretty narrow and specific diagnosis criteria that may contradict home care. I'll now pass it off to Johnston.
Thanks, Amanda. If hospital at home is going to be a better model of care than care actually delivered in the hospital, then it needs to compete on quality, cost, and access. In terms of quality, studies so far have consistently shown that measures of quality and outcomes are at least on par with care provided in the hospital. You've already heard some statistics about improved outcomes, and I'd like to highlight a few more from recent studies. Readmission rates are frequently much lower for patients who are treated at home, which could be due to patients learning how to appropriately care for themselves during their hospitalization. A recent study, which measured movement using a skin sensor, found markedly higher mobility rates with less time spent in bed, which is believed to be an important condition for fast recovery for many different types of diagnoses. And escalations in care are lower at home in some studies, meaning that patients do not deteriorate as often. There are other improvements that have been reported as well, such as higher patient satisfaction and fewer falls. While there are some exciting improvements in outcomes, cost is perhaps the most compelling reason to shift hospital care into the home. All studies to date have shown lower cost of care when compared to just traditional hospital stays, but the amount varies based on the population and the way of measuring. For example, one study found that adjusted costs were 38% lower during the hospitalization period, but only 36% lower if the 30-day post-discharge period was included as well. And another study found savings as low as 19%. However, this is likely because of differences in measuring the savings and because remote patient monitoring technologies were not widespread at this point in time, so not included in the study. These savings at the individual level could add up to a very large savings at the population level. Previous studies have found 70% of costs are generated by about 10% of patients. And so if hospital at home can effectively be provided for those highest utilizers of care, then we could save almost $300 billion per year in healthcare spending as a nation. However, even if these high utilizers are not a good fit for the program, if only 10% of average patient admissions could be done through hospital at home, it would still represent over $150 billion in savings. However, it's worth pointing out, as mentioned earlier, that currently the CMS waiver program pays full MSDRG rates for these patients. These savings will not be realized unless new payment models are developed that appropriately reflect the cost of care. Finally, while access is very important, it is not as yet well studied and offers conflicting points of view. One study looking at patients found that those who chose to participate in the program were actually more likely to live in poverty, which is a good sign for access. It also theorized that older adults who serve as the primary caregiver for a loved one may be more willing to participate in home-based hospitalization, so they can still serve that role. On the other hand, it's common, as mentioned before, to have program exclusion criteria such as internet access, heating, or air conditioning. So some are worried that this will preclude this care option for segments of the population that are already at higher risk of worse health outcomes. More studies are needed in this area, and research should be done to establish whether access is improved or at least on par with other forms of hospitalization. Now I'll pass it off to Jitendra.
Thank you, Johnston. Before summarizing the recommendations for the hospital at home program, I would like to thank all my team members. We are focusing on this slide that what prevented hospital at home from being successful before. There are a few important elements that we need to focus. It will help us to ensure the future success for a hospital at home. The most important was the lack of predefined eligibility criteria. There was lack of consensus in 1995 and even after that which patients are qualified for hospital at home care. The other important element which caused the failure of this program was its small scale with no randomizations. We need to resolve challenges with the supply chains, as we know that in hospital at home, we are moving supplies out from the hospital to the patient's homes, and supplying medically necessary equipments and other elements of the hospital at home care environment is a challenging task. Lack of reimbursement schema as well as the coding system was also an important reasons for the failure of the hospital at home in the beginning. Issue of equity. Telemedicine is an important tool in hospital at home, but we find out that there is an issue of equity regarding using telemedicine as a tool. So it has been observed that homeless people or people living alone can get easily excluded from telemedicine-based hospital at home care. Addressing the disparity by providing added incentive to provider to focus on patients group with potential exclusions. Lack of patient-side clear information regarding effective use of telemedicine could also cause problem of equity. We can address this by training the patients in telemedicine before hospital discharge or by the staff before the starting of hospital care at home. Speech, hearing, and vision disability is also an important issue. Telemedicine devices with added support feature for speech, hearing, and vision disability patients need to be provided. Future recommendation. Broadly, we can have few future recommendations to ensure the successful implementations of the hospital at home program. Developing a better reimbursement model. We know that currently CMS has approved the payment under COVID emergency protocol. We need to make sure that post-COVID care, as well as the Medicare Advantage and other managed care insurance, accept hospital at home care reimbursement model. Integration with other care outcomes homes, especially end of care and hospice care. Increasing the safety of patients and caregiver as they are outside the secure environment of the hospital. Developing a regulatory policy in terms of patients' rights in hospital at home care program. Thank you for providing this great opportunity.